meeting roster. So with that, I'm going to call to order the May 7th, 2024 Oregon Educators Benefit Board meeting. We are meeting virtually, and my first job is to welcome all of you and thank you for your presence. We'll do a roll call to see who's here. Cheryl?
Here. Thank you.
Michelle?
Here.
Sally?
Here.
Bill?
Here.
Bonnie?
Here.
Sue?
Here.
Robert? Enrique? Susan Miller? Bob Stewart? So we have a quorum. We are missing, though, 4 members. It was possible that Bob was not going to be able to join us this afternoon. So Rose, if you can keep track of when Robert, Susan, and Enrique join us, that'd be very helpful.
Okay.
Okay, thank you. Okay, so with that, we have the April 2nd, 2024 minutes to approve. Is there any question or issue that someone wants to raise, or do we have a motion to approve?
I'll move. Oh,
Bill,
sorry.
Bill,
go ahead.
ahead.
Go ahead. You go. You go.
I'll make a motion
Bill
to
moves.
approve.
Okay, thank you very much. That's Sally.
Yeah.
Second from Bill.
Second from Bill. And Enrique has
Okay.
arrived.
Oh, wonderful. Hello, Enrique.
Hello, everybody. Thank you.
We're just approving minutes. Okay, all in favor of the approving the minutes, say aye.
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 Opposed? I hear no opposed. The minutes are approved. The first item on the agenda is board election and affirmation of officers. This is for the 24-25 plan year. Ali, you're on.
I am. Thank you so much, Tom. And as you all know, Tom is retiring off the OEBB board this month, and we'll have a chance to say a lot of really nice things about Tom today and thank him. And but we need to replace him as the OEBB chair through the end of JJ Schofield's 2-year term, which is through the end of June of 2025. So according to the OEBB statutory authority and the bylaws, the remaining 1 year of this term of the OEBB chair seat must be filled by a non-labor position because the previous chair was a labor position and it alternates every 2 years. So with Bob and Sue retiring, that leaves only the district management and local government management seats that are filled as eligible to serve as chair for the remaining year. At that time in June of 2025, Enrique, as vice chair, would be eligible to serve as chair for that next 2-year term. So with all of that, if I could request from the board a nomination among those non-labor board members that are eligible. This would be between Bonnie Luisi, Bill Gropp, and Cheryl Berger. They would be eligible as candidates to serve as OEBB chair through June of 2025. Any nominations for those three, or even from those three, anyone willing to step into that role?
This is Susan.
Ali, I'd like
Robert?
I think Susan beat me to it, so I
Okay,
don't know.
Susan?
I'd like to nominate Bonnie Luisi.
Okay,
And I'd like to nominate Bill Kropp.
okay. Are there other nominations? Now the question is for each to ask each of the nominated individuals whether or not they are interested in filling the role as board chair. So Bonnie, you were nominated first. Do you have interest in filling this role?
Yes, I do.
Okay. And Bill, do you have interest in filling this role?
Yeah, I would love to be
Okay.
the chair.
Okay, so we have two people who are interested in, both have been nominated. Ali, I don't know what the process is for us to do this. Do we have speeches? Do we do a month of campaigning? I'm waiting for balloons dropping from the ceiling, but maybe you can tell us what we do.
Yeah. So what we'll do is we'll have Rose send out a ballot, and she can record the votes.
Perfect. Okay. And Rose, if you can do that over the next week or so, that would be helpful, I think. And we
Sure,
may
sure.
Ali, would it be helpful to have maybe a brief, if the two candidates could give a brief, maybe a 1 or 2 paragraph note that they'd sent to Rose that would accompany the ballot, would be, I think, helpful for, kind of interest, what explains their interest in filling the position of board chair and what they view as their qualifications for such.
Yeah,
that makes sense.
Yep.
Yeah. So Bill and Bonnie, if you could please get that to Rose by the end of this week, and then Rose, maybe next Monday or Tuesday, if you can get the ballots out to the board members, and let's have it by kind of close the election as of the end of next week. That would be the 17th of May.
Great.
Is there anybody who wants to change that process piece, or does that sound okay? I'm not hearing any complaint. So if there isn't any, if there's no complaint, I'll assume that that the process that I just outlined will work. Statements to Rose by the end of this week from the two candidates, ballot out early next week, close of election the end of next week, May the 17th. That'll give time to getting the new board chair integrated into the upcoming leadership meetings.
Wonderful. I was just hoping to get one, so to get 2 interested people is great. Thank you.
Okay, perfect. Thank you very much. And thanks for both Bonnie and Bill for being willing to step forward. That really means a lot. Okay, we now are going to have Mercer and our consultant Kirsten talk about final approval of final rates for the 24-25 plan year. Kirsten, you're on.
Great. Thanks so much, Tom. Hi, everybody. It's great to see you all. We have a ton of detail in this deck. Most of it we will not have to go into this afternoon, but we did just want to include it to make sure that we were documenting everything. So we're going to start off with an overview of where all the final decisions and the overall renewal landed, because I know last month was a really full month and we had to make it through a lot of material. And then always in this May meeting, we approve the rates, and all of the premium rates are actually included in this deck. We will not go through them all. We'll just approve them in one big chunk. So thanks for bearing with us as we go through and let you all know where things landed. And Maggie's going to be running the slides today. Thanks for that, Maggie. We can go ahead and move on. Looks like to slide 4. Great. So we like to illustrate where OEB lands each year overall, and we have so much history now with OEB. We also like to show it in context. So on this slide, we'll look at the overall renewal increase for 24-25 that we're projecting, alongside the last few years of renewal increases. So overall, based on our enrollment snapshot that was used for all of the renewal projections, we are anticipating an overall renewal increase of 3.38%, so just a tiny bit under the 3.4% cap. That compares to an increase of 3.4% last year, 3.2% the year before, 1.1% for the 21-22 plan year, and 1.6% for the 2021 plan year. And I know we've talked about this at different stages throughout this last year, but it's been a really interesting time from just a macroeconomic perspective. And we had the couple of years immediately during and right after the pandemic, and that caused a couple of really low increases. And then I know you've been witness to that this year, and we've talked a little bit last year as well. Now we have upward pressure from macroeconomic forces. So to achieve 3.38% in light of everything going on and historic inflation and higher pent-up demand after COVID is just really meaningful for your members. On the next slide, we'll look at OEB's renewal increases compared to the commercial market. And I just want to let you know what this is. So for the commercial market, the benchmark that we have is the medical pharmacy increase. That's a little bit different than what we looked at on the previous slide, which includes dental and vision rolled into that as well. So this is medical pharmacy. And then because our benchmark does not include benefit changes or changes in taxes and fees, we've excluded that here. It mostly doesn't matter because aside from the 24-25 plan year, we haven't made any benefit changes, but it is just a small factor impacting 24-25. So you'll notice immediately you'll see that the purple bars representing OEB are much lower than the commercial bars in navy blue. And in fact, if we look at the last 5 years, the cumulative increase average is 6.14% for the commercial market and less than half of that for OEB at 2.81%. Again, just really, really illustrating the tremendous value of OEB to its members. The next slide, Maggie, please. So we wanted to illustrate for you where we expect the 255 entities that we have enrollment data on, where we expect them to land, because we have for each entity, we know what plans were offered and enrolled in for members in that plan as of December 2023. So we can project using all of the different renewal increases by plan and carrier. We can project what we think each entity is going to get for 24-25. And then we've plotted that here. So let me just orient you briefly. So the projected renewal increase is along the bottom. So the first thing I want to call out is that nobody is getting larger projected to get more than a 3.9% increase. So that's really incredible. Of course, I want to caveat that open enrollment results, so people switching plans, districts switching which plans are offered, dependents coming on or off. There are several factors that can make actual results different than this. But just looking at the enrollment snapshot that we have, we would expect no entity to get over 3.9% increase. And in fact, 79% of entities would be expected to see 3.4% renewal or less. If we look in the range of up to 3.6%, now we're estimating 96% of entities. So only a small handful of entities, maybe who are concentrated primarily in Kaiser, which had the higher of the 2 medical increases, would see anything over 3.6%. Next slide, Maggie. Here's where we landed by carrier and also by coverage. So we have the two medical plans first. MODA came in right at 3.4% without any medical benefit changes or rate subsidization. Kaiser's final round 3 renewal increase was 8.6%. That did reflect both a concession on their part and also the application of the trend guarantee payment. And actually MODA's rate reflects the trend guarantee credit as well. And then after the $6.5 million RSR subsidy and also some minor Kaiser benefit changes, the Kaiser medical renewal was brought down to 3.99%. For the dental renewals, Delta Dental, Kaiser Dental, and Willamette, Delta Dental is renewing at 2.93%, Kaiser at 3.67%, and Willamette Dental at a rate hold. For the 3 vision plans, MODA, Kaiser, and VSP, either a rate hold or small decreases for all of those plans. When we blend all of those increases together and weight them based on premium, we get 3.38%. And this is with the use of $6.5 million in Kaiser's rate stabilization fund that was approved last month. Maggie, next slide. We do just like to document, especially as we go on, what's happening with the rate stabilization reserve balance, both what the rate stabilization reserve balance is paying for, and then also what we anticipate the ending balance to be. So for the 24-25 plan year, there 6.5 million of Kaiser's balance is paying for rate mitigation. We also have Weight Watchers, which was approved for 1 more year for OEB, a minimum of 1 more year. That's going to get paid for with RSR. We have 1 more year of the VERTA program that was new last year, 1 more year of OMADA and Pre-D. And then we have the new breast cancer member education and screening vendor called Gabby. It's going to be a 1-year approval as well coming out of RSR. So that takes us down to $21.4 million estimated. Of course, as the year goes on, especially after we end up in the 24-25 plan year and we can see how much is actually spent, and that will vary based on enrollment, then we can come back next year during the renewal and reflect what was actually spent. But our estimate at this time is 21.4 million ending balance. And then on the next slide, we just show this graphically over time, just because we like to show things visually. I think it helps for those of us who are visual learners too, just to see the balance split between MODA and Kaiser as well on this slide. MODA at 14.9 million and Kaiser at 6.5 million remaining for 21.4. So we'll move on to section 2. We're going to recap. Oh, sorry, Enrique, I didn't see your hand.
Hey, no, I was just waiting for the last section of the slides to go, so I appreciate. So my question is on slide number 5. When I'm looking at the board packet, thank you, that one. Is it the data that we have here on the market average and the OEB average? Is that beating the market by quality and price, or just by price? Like, does that make sense?
Yeah, it does make sense. I understand what you're asking. So, it's going to represent price. So we're in other words, we are not attempting to adjust the renewal increase to reflect differences in changes in benefits over time. This is a survey of employer groups and what their premium increases are as well.
But Kirsten, I would add the up until 2024, our benefit, we had no decline in our benefits, and so at least from a benefit standpoint, that was very stable. And I haven't heard any effort in the market of increasing benefits.
Yeah, and
as a,
maybe that's helpful, Tom. And maybe Enrique, I should have asked you to clarify a little bit about what angle you're coming from. That probably helped me answer your question a little bit better.
Yeah, so I guess my question is more of, we have this sort of prices that the market is fluctuating, and you provided an example of what's the private market showing and also where we are within OEB. So my question is, we continue to have this price increase, and we, as Tom said, we continue to have the services that we are. So I guess my question is, we continue to increase the price to our members. You know, we continue to compare or members continue to compare the services they're receiving. And this specifically goes to the rural areas, right? Because they see, you know, they see Moda, Kaiser, and other providers. We have the services for you. However, they don't feel they get the same sort of level of services as compared to the urban areas and some of the areas that have closer medical providers. And this is not an OEB fault per se, but the quality and the price, you know, it's just, that's what people are looking at.
That's great. Michelle, I see your hand too. That's really helpful, Enrique. So what I'm hearing you asking is, you're just wanting to make sure that the lower OEB increase isn't reflecting, let's say, lower quality or lower service or lower level of benefits to OEB. That makes a lot of sense. Yeah.
Yeah. So I
I'm
guess
glad,
my thing is, like, I think OEB's doing a lot of good work. But I've been traveling around the state, and I was in Bend last week, and I was in other parts of the state, and my members continue to say, oh, our OEB members continue to say, well, great, but, you know, the services here still continue to be not as approachable for us. But I want to be able to tell the story of, look, OEB is doing amazing work. This is the best work, the best services you can get. For instance, if you go to the private market, or if you go to PEP, or if you go to, I don't know, Blue Shield, whatever, I want to make sure we're able to brag about our wins and say, yeah, even if you go outside, you're not going to get the same sort of like services. So I guess that's where I'm coming from.
Yeah, I'm going to try to just see if this also gets to what you're talking about. There is no question that there is disparities in quality and quantity of services across the state, and the biggest divide has to do with rural versus urban. And you know, in urban, you get a concentration that allows for what you see, and it's a struggle to maintain that same degree of clinical quality and availability of services in less populated areas. It's been looked at nationally, and we have a crisis in rural America in regards to availability and affordability of medical services. There's an economy of scale for particularly complex medical technologies that just are, it's almost an impossible nut to crack. If that's what you're getting, if that's what your members are saying, you know, they're saying it's expensive and we don't have the same quality that we have in Portland Metro or Salem, or, you know, again, the higher population areas. And that's just true. And it has to do with a multitude of reasons, but the state is struggling to address that. Is that what you were getting at,
Yeah,
Enrique?
Tom, yeah, maybe a different topic later on in the conversation, or, I would like to us to discuss how can we tell our members that we're providing them a better services than in the private sector. That's all. Thank
Yeah.
you.
Yep, I got it.
And I see Michelle with her hand up, sorry.
Thanks, Enrique. I really appreciate you having us all pause on this point. And I would just say that, you know, keeping premium costs down is like is not providing healthcare. They're not the same thing.
Okay.
And it's good that our premium costs have only increased at a much lower rate than the private sector, but I don't think care is improving. I think having a $1,200 deductible is a huge barrier for members. In my family, it's $1,200 per person. So there's hardly ever anything that is covered in the course of a plan year for my family. And I also have a member who, actually, we have several members who have PEB, who have family members who are in PEB, who can see very clearly that the benefits that PEB members have are much, much better than what we have in OEB. And in fact, I'm supporting this member who's putting together a table comparing PEB to OEB that we're going to distribute among our members just to start this conversation, because I don't get the sense among my members, despite all the good work in this group, I don't get the sense that my members are feeling like, wow, OEB benefits are great.
I think that this is the disparity between OEB and PEB is one that is true. It speaks to funding. And Ali, you're the right person to talk. So I see your hand get up. So.
Oh yeah, I mean, yeah, I think it's really difficult to compare the two programs. PEB is a Section 125 cafeteria plan that, all members must be offered the same plans at the same prices. They're, negotiated in collective bargaining agreement with the state. Very few employers, just universities in the state. They've really prioritized benefits in their negotiations over the years, whereas OEB operates more like an exchange, offering several more plan options. There is a high value, quote, platinum planned with OEB, like there is with PEB, but obviously not every entity participating in OEB offers that plan or offers all the plans. So, and the fact that OEB has collective bargaining agreements with, in the hundreds, and really the Section 125 is with the individual employer or school district or community college. So just several differences. I totally understand the argument and why an OEB member would see, the all Cadillac plans offered through PEB, and if their district isn't offering, the one through OEB, then seeing a disparity there.
I think the issue is as a board, we are not involved at all in terms of what the entities are willing to pay for services. And as this concept of us being an exchange, we have done an excellent job being able to offer a variety of affordable options, and they've been more affordable over time than what's happened in the marketplace. But it does not at all speak to the issues that both of you two are representing as you talk about the people that you represent. It's unfortunate, but it's not within our capacity as what OEB has been formed to do. The issue of how much the school districts and local governments are willing to pay and offer their employees in terms of health services are just that's not something that we are involved in. Our job is to try to give them as many affordable options as possible. And again, we've done that well, but we haven't addressed the fundamental issue of funding of healthcare. Does that, are we able to move forward? Again, well-spoken concerns, but at least from my perspective, and I think Ali's, it's beyond what we're formed to be able to address.
Tom, Susan Miller's hand is up too.
Okay, Susan, I didn't see it. I'm sorry.
Thank you, Kirsten and Tom. I just wanted to point out, I mean, not lacking any hard work in this room, obviously, and we've been able to do a lot with OEB, but I do feel the need to make it clear in this room, because I don't know how experienced people are around collective bargaining, but it is not an option to have PEB in the entities that have OEB as an option. So
No,
it isn't
it's not.
as easy as saying,
Yeah.
you know, it's not just the entities wouldn't invest in it. It's just not an option. So I feel like that's a pretty
Very true.
important
But I think what Ali was saying was our both Moda's and Kaiser's, like Moda's Plan 1 and Kaiser's Plan 1 are pretty close to the PEB's offerings in terms of plans. The difference, though, is each entity decides how much they're going to, in OEB, decides how much they're going to fund, while at the level of the state, and my understanding, Ali, is that it's funding at the 99 to 95% range.
Yeah, it is.
So
and really comparing apples to apples, I mean, PEB is an older population with a much higher risk profile than OEB. So like dollar for dollar in actuarial value, OEB's actually a more economical plan offering across the board. So, but Tom's right. I mean, with PEB, the contributions like 99% to 95%. So that's a big disparity, obviously.
I appreciate the what you're pointing out there, but I do also feel that in collective bargaining, the members that we're representing are choosing to also put in whatever percentage. I mean, that's all done through negotiations. So I'm just saying, if you were to put PEB as an offering alongside OEB, I think you might see that people are going to choose the Cadillac plans and PEB over OEB, even if they have to pay more to get into it.
Yeah.
Robert, you had your hand up.
Yeah, thanks. Sorry, my camera's not working today, and I don't want to drop off. I appreciate the comparison to PEB, but I think we also need to make the comparison of what it would be like if we didn't have OEB. And there's a reason we have OEB, because every individual school district could not get the same deals that we're getting with OEB. So if OEB broke apart, we'd be worse off. And so, we have the 3.4 restriction, and if we go higher than 3.4, then we're have to cut benefits to match it. I mean, we have a lot of things to play with or have to respond to that PEB doesn't have. But without OEB, almost every single school district would be incredibly worse off. It'd be more like this chart that we see above.
That's a great point, Robert. In my director's report today, I was going to mention that Medford School District is coming to OEB voluntarily starting October 1st. That's 1,100 employees. And I think that's a true testament to the work that's going on in OEB. And, while it's on the I-5 corridor, I think there's, you know, there's some rural parts of that area that, you know, again, it's hard to compare with PEB, who's got 3 carriers overall, or 2 statewide carriers versus OEB, but I think the coverage is pretty good, and we're always talking with entities out there trying with our OEB advisory group to try and really push as much as we can for greater access.
It's a really important discussion, and maybe I'll just comment with a couple things, maybe more from the actuarial perspective. But it was so helpful to hear you all share your really thoughtful perspectives and insights about what your members are saying and how the plans are being perceived. There are some real reasons why we expect OEB to have lower premium increases each year compared to the commercial market. And Enrique, if we want to make some, you know, a summary list of some of the ways that OEB delivers value beyond the commercial market, one of the first things that comes to mind is the power of Senate Bill 1067, which caps certain hospital payments at 200% of Medicare. So not only does that lower the cost of care, and that benefits all members in the state of Oregon, not just the members that go to the hospitals that are impacted by Senate Bill 1067, which tend to be the larger systems along the I-5 corridor. Because we pool all of the member claims experience together for the purpose of calculating premium, that hospital savings benefits rural members and also urban members equally, and is a tremendous value to OEB. And not only does that result in lower premium each year, but because Medicare trends at lower rates each year compared to the commercial market, that also results in a lower year-over-year increase compared to the commercial market. And Michelle, I really hear your point about you know, looking at the value of a plan, and absolutely, it's really important to keep in mind that premium is one aspect of affordability. We also have cost share and covered services, and affordability is one aspect of good healthcare. But I do believe that when we look at all of the work that OEB has accomplished last year for 23-24 and also for 24-25, and take a holistic look, OEB is delivering value in all of those areas, and it's certainly not to minimize the member experience. My son and I are also in a high deductible health plan and really receive like no value from our own plan. So I 100% understand where you're coming from on that as well. I know we have conversations about the HSA. We have them every year. But if we look at the other things that we have going on within OEB, we didn't have to increase deductibles this year. We didn't have to increase the out-of-pocket maximum this year. Those are both really important overall financial protections for members. And we also were able to add many services, and a lot of them were specifically added to help our rural members. So because OEB has this ability to be really innovative in the kind of care that it delivers, and CIAO supports OEB's ability to be innovative, as does OEB's partnership with its carriers, which is really unique compared to the commercial market. How much MODA and Kaiser and VSP and Willamette Dental come to the table to have collaborative conversations with you. It's really unique. And because of that partnership, OEB was able to offer doula services. And then also in this summer, we're going to explore a category of provider called traditional health worker. And both doulas and traditional health workers are additional in-person resources for communities, specifically thinking about rural communities, because we know that there is harder to find in-person care. And then we also are adding teledoc for 24-25. And again, everybody is going to have access to teledoc. But it was really with an eye towards our rural populations, with an understanding that, you know, we know there's a disparity in care. You're going to hear John Kessler in a few minutes with the dental performance guarantees. You know, we're reinforcing this idea of closing gaps in care between rural and urban members in our dental performance guarantees as well. So it is an important theme consideration that we are focusing on and are making some important progress towards in 24-25, and we'll continue to work on. And then, in terms of enhancing benefits, the richer a plan's benefits, the more expensive the plan. And that happens for two reasons. The plan is picking up a higher proportion of the care. And also when members have richer benefits, they get more care. Sometimes that's good, right? We never want cost share to be a barrier to care. Sometimes there can be a little bit of overuse of care as well. But we also have other initiatives too that we'll consider. But I think, and I took notes, and I know my team did as well, that these are all conversations that we can continue to have during the next cycle for OEB starting next September. And we're going to see, Maggie, if you go one slide forward, we have, sorry, let's see, I meant back from where we left off. So I think if you just fast forward, let's skip over 11 and let's look at 12 and 13. Because again, those slides about renewal increase, certainly the message was not to suggest that OEB delivers value only because of the premium increase. It is definitely part of a holistic story about value, in particular, a lot of care about our members in some key areas. So in the green are existing programs that we have in place for addressing cardiometabolic disease. And this is a condition that we've been really focusing on with the board and CIAL throughout the last year. So already in place, VERTA for type 2 diabetes treatment and reversal, OMADA and PRE-D through MODA for type 2 diabetes prevention, Weight Watchers for weight management, and Livongo for self-type 2 diabetes management. And then also an expansion of the nutrition therapy benefit through MODA. This is not a nutrition therapy feeding. This is nutrition therapy as in dietitian counseling. OMADA, weight management, and also Mighty weight management. So 3 more tools for members to help them delay progression and avoid developing entirely cardiometabolic disease. And then if you go forward one more slide, Maggie. Also, in terms of closing gaps in care, we have existing programs, and Mercer has talked about this a lot. We know that we want to do more for our rural members than just simply add more virtual solutions. And that's really why we focus so much on doula services, and we'll be talking about the additional in-person provider types through traditional health workers. But virtual care is an important tool in rural areas. And we have already in place today, Maru, virtual cognitive behavioral health therapy, CRSMD, and there was some negotiation success with this as well to lower the cost a little bit for CRSMD, but that's virtual urgent care. SWORD is virtual physical therapy, and Behavioral Health 360 is additional providers and also some concierge support for helping to find the virtual behavioral health provider that's a good fit for you. But then adding 3 new initiatives. So Teladoc. Teladoc is a virtual primary care network that's going to plug into MODA's PCP 360 network, which means members who access Teladoc providers will get that preferred CCM benefit. Doula services to support positive birthing outcomes for the birthing parent and also the newborn. And then Gabby for breast cancer risk detection and imaging. So 3 new solutions here as well, really working hard to close gaps in care, doing what we can now, knowing that we're going to continue to work hard next year as well to do even more for your members. On slide 14 and 15 and 16, we don't need to spend, and actually 17 as well. We just have a recap, again, for the purpose of documenting. We don't need to run through these all. We've definitely covered the highlights. Thanks, Maggie. That's all of the decisions that were made last month. And then section 3, and I'll stop here, Tom, and ask how you want to do the rates for approval. In section 3, down through, just scrolling here. Yeah, all the way down, the rates stop. Oh, the rates stop at slide 79.
Yeah. So why don't we show one example from each of the like Moda Medical. Let's show one and just show what happened. So if you can take, this is a great example. Okay, so this shows what's happened to the 8 Moda plans that we are offering, and it shows what they're paying now in 2023-24, what the new is, what's the increase in regards to per employee per month, and percent changes. Now you'll notice in the upper part there's employee only tier, and for each of these you'll see employee only, employee and spouse, employee and children, employee, the entire family, and then composite. Those are all the different ways that the plans are offered. But and you'll see those outlined for each of them. But essentially, what you'll notice is the percent change is what is consistent for all the Moda plans. Robert, you had a question or a comment?
I do. So I pulled down the rate sheet from the OEB website for 24-25, and I just want to let you know the numbers don't match. So I don't know which one's right or correct.
Well, I don't know why there'd be 24-25 out there, because I don't think we've done the final approval yet of rate. So it's kind of hard to.
I'm looking at it right now.
Well,
hey, Robert. So one nuance: these premium rates are the carrier approved premium rates that do not yet have the OEB administrative fee, which is included in the rates online, so they will not tie.
Okay, because the carrier rates don't factor into the 3.4, I assume. Is that right?
It's a little bit different than that. So the carrier renewals and the negotiations that we do with them and the rates that we saw last month as well, the rate increases you've seen earlier today, result in these rate changes. But then an OEB administrative fee for administering the programs is added to the base carrier premium rate. And that is the rate that is online.
I appreciate that. The reason I found out about the rate sheet is because I've had colleagues already pull it down and say, are these the correct rates? And then I was looking at the board presentation and I don't know what to tell them.
Well,
the rates online are the correct rates.
Okay, thanks. That's what I need here. I appreciate it.
So we do not need to approve them because they're already published? Ali, do we have to?
Yeah, you still need to approve
these
them
rates when they've already been published?
Yeah, there's carrier rates and then there's OEB member entity facing rates. So,
seems a little. It seems a little backwards if we haven't approved them, but they've been published.
They haven't been published. I think some initial rates were shared based on decisions because for people that were in collective bargaining. Some of the entities are clamoring for the rates as soon as possible, as soon as they're hot. Okay. Yeah.
All right.
It's always been the case. Yeah.
Again, I pulled it from the OEB website. It says new rates, and I pulled the document, the PDF.
Okay. It's like Cindy has
so it sounds like we need to approve the approve these rates.
I just want to
someone else has
clarify
their hand
these
up, but
rates.
I can't see who it is. I'm sorry. I'm just trying to
It's
find
me,
out
Tom.
whose
Cindy.
hand is up.
No, it's
Okay, Cindy.
Cindy. Yeah. So Sarah Sarah just said she just put these up there on the insurance committee's webpage because the entities were asking for it. So we can sure pull them down if you'd like, but
if
we have them up
indeed the
there for
board,
the.
I'm just talking about in the future, if the board has to approve rates, having them posted before the board approves them doesn't seem to be appropriate. I understand the people wanting to, then we should move our board meeting earlier than the first week in May if our entities need it sooner. But you know, it seems a little silly that the board is now asking to is being asked to approve something that has already been published as a done deal. That's all I'm saying.
Appreciate that. Yeah, I think you're right, Tom.
Okay,
Yep.
so with that in mind, we could spend about 14 hours going through all of the detail for the next 50 pages. I don't think we want to do that. I think what we want to do is to get the to acknowledge for MODA, as you see here, all of the changes, again, before the OEBB administrative changes, reflect the 3.4. Kirsten, could you go down now to employee only for Kaiser Permanente? And we can see what happened there with theirs. So here is employee only for Kaiser's medical renewal. And you can see here, these numbers change some. Can you explain that? While MODA had the 3.4 across the board, Kirsten, what I'm seeing here is the plans have different percent changes.
Hi, Tom, that's right. So earlier on in this presentation, the overall Kaiser medical renewals expected to be 3.99%, but we made some small benefit changes to the Kaiser plans, and they impacted each of the plans that Kaiser's offered a little bit differently. And so that's why if we averaged all of those increases together, 4.03, 3.63, 357, 394, and 294, if we averaged them all together using a premium weighted average, we'd get 3.99%. But they vary here by plan because of the benefit changes coming in.
Okay, does everybody understand that? Or is there any additional questions or comments about why the Kaiser plans, the percent changes differ? I understand exactly what Kirsten has said, but some of you may have questions about that. Okay, so we've now looked at the employee only tier for Kaiser Medical and MODA Medical. Can we show an example of Delta Dental? So here's the employee only tier for Delta Dental, and you see again a small differences in the plans, and that probably there was a slight change in benefits with Delta Dental, just like Kirsten talked about, but the changes are almost minimal. Any questions about that?
Tom, just to clarify, the one change that was made to the Delta Dental plan after Michelle Dewberry raised some concerns about the dental waiting period, we were live in the meeting last month, able to work with MODA / Delta Dental to eliminate the waiting period, but with no premium impact. So this is, you're just seeing a little bit of rounding. It's kind of annoying. It happens like that sometimes.
Okay, all right. So now can you show the Kaiser Dental for employee only? Okay, and this is just, they have just one plan. You see there the 3.67. And now can you show the Willamette Dental? and they had no change in their rates. And the next one would be then for the 3 vision plans, the MODA, and again, small, teeny, actually negative changes. There's actually a decrease in the per employee per month increase. Kaiser Dental, Kaiser Vision, and then VSP. And then VSP. So, you know, again, each of these rate increases, I've asked Kirsten to show the employee-only tier. You know, there are, again, 5 different options that that have to do with how many people are included, or whether or not it's a composite. Any questions about these rates? Because it sounds like what we do need to do is to, we need to formally approve them. If there aren't any questions about the rates, I would entertain a motion to approve them. I don't think we need to, actually first, do people feel comfortable with approving them all as outlined, or do you want to go through them individually? Any comment?
I'm happy to bundle the rates if the board's okay with that. If not, I'm happy to go one by one.
Okay, so does anybody want to go through this on more on an individual per plan, per area, medical versus dental versus vision? Or if there aren't any, I mean, I think this is relatively straightforward. I'm seeing a note from Sally, okay as a bundle, and Ricky has said that if there's anyone who wants to have different one after another, otherwise I'll entertain a motion to approve all of the 24-25 renewal rate changes.
I move to approve the 2024-25 renewal rates changes for the OEBB board.
Second.
A
by
lot
Sally.
of seconds.
I didn't get the second.
Sue, I'll second.
Sue, thank you, Sue. So Enrique moves and Sue. And this one, we're going to do a roll call vote just from its importance. Enrique?
Yes.
Cheryl?
Yeah, yes.
Michelle?
Yes.
Sally?
Yes.
Bill?
Yes.
Bonnie?
Yes.
Sue?
Yes.
Yes, I'm sorry, Sue. And now Susan?
Yes.
Robert?
Yes.
And did Bob Stewart join us? He was a last minute unable to come. So the rates unanimously are approved. Now that is for, so far we've talked about medical, dental, and vision. Robert, you had a question?
Yes. Just so I'm just going to go back to the premium differences on the board presentation versus the rate sheet. I understand there are differences, but I've actually been coaching my colleagues to actually look at the board packet, and when they don't line up, I'm going to have to answer the question. So maybe it's something for the future that, you know, what we're approving, you know, lines up with the posted rate sheet, or have an explainer so I can explain why they're different.
There needs to be, I agree. I think there needs to be a huge caveat that says, you know, these rates are before the OEB administrative fee. And what that, Ali, my understanding is that has been consistent since the inception of OEB at 1% or 1.5%.
No, it's fluctuated. It hasn't
okay.
moved in a few years, but yeah, it's
Okay.
fluctuated.
Okay, so that needs to be outlined, and it also would be helpful to send to the entities what what that range has been. Is it averaged 1.5%?
It's lower.
It's lower than that. Okay.
Yeah, it's average something lower. But
Yeah.
yeah, I mean, we can schedule a quick
Yeah.
board meeting, in April and do the rates.
Yeah.
But yeah,
Because we need,
Robert, sorry,
if
these are
if the
carrying
entities,
rates.
if the entities need the rates before we meet in May,
They do. Yeah.
then the idea of having us approve them after they've been published is, some people would call it back assword, but whatever. Okay.
Yeah.
Let's now, Kirsten, you have other rates for us to quickly look at. They are the ones for the other benefits that we provide, the short-term, long-term disability, life. You have, this is the renewal rates for the COBRA administration. Explain this one for us.
Yeah, so the percent change, it's just a sort of a side effect of having a low rate to begin with, and then a PEPM increase of 3 cents. So John worked really hard to negotiate this renewal increase for the BHS administration down to 3 cents. And then, that results in a kind of a strange percentage increase just because the starting amounts are so low.
Now, this is, explain the BHS. This is the company that takes on the additional administrative burden of dealing with COBRA, correct?
Right, that's correct. This is COBRA administration. So there's some additional administrative work that goes into the management of COBRA premium and enrollment.
Okay. So is there
just one quick
Yeah, go
comment,
ahead,
Tom. This is John.
Yeah.
They haven't had an increase. They've had very limited increases in their history with OEB, and they're just really trying to play catch up at this point.
Okay. Is there any question or comment from board members around this renewal rate? Because it's another one that we have to approve. If not, I'll accept a motion to approve the BHS renewal rates as outlined.
Tom, this is Cheryl. I will put a motion forth to approve the BHS renewal rates as shown.
Thank you, Cheryl. A second?
I'll second it.
Second.
Bonnie, second. Is there any comment? All in favor? Say aye.
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 Opposed? Opposed? No, it's unanimous. Okay. So can we bundle the next ones? Oh, Robert, you have a question.
Not a question, an apology. After people had posted in the chat that the numbers were the same, I realized I made a huge mistake. I was looking at the 23-24 column and not the 24-25 column. So I take everything I said back with a significant amount of shame.
Well,
No
as
worries.
as Emily Latella said, never mind.
No worries.
Okay, on to the next series of renewals. Kirsten.
Yeah, so these are the life and disability renewals. So for life insurance, short-term disability and long-term disability with the standard, OEB is in a rate guarantee. So no action is needed on those. The rates are shown for informational purposes only. For Unum, those plans are guaranteed issue, no rate or other changes to note. There is the conversation about moving to direct bill that's happening in the background, but no rating actions needed on these ones, Tom. It's just informational.
Okay, so but we still need to approve them? I assume we have to approve the 24, 25 rates for these. Help me out, folks. Ali, do we need to approve these?
No, you don't.
Okay, then we're done. Thank you.
Yep.
All right. And Kirsten, go ahead and tell us about Appendix 7.
Yes, so in the appendix, I'm scrolling down in my big PDF as well. I'll tell you what's in the appendix. There's a second set of premium rates called the surcharged rates. These are 17% above the OEB base rates that you just approved. Certain cities and counties, depending on an underwriting process, sometimes come into OEB at the base rates, sometimes would be eligible to come into OEB at the surcharged rates. So that's what those are here. And then we also have, after the surcharged rates, we also have some documentation around plan-wide administrative changes that MODA and Kaiser are making. And then we documented just a couple of the other random benefit decisions that the board voted on last month. For example, expanded dental benefits for members with developmental disabilities, the Costco 6 for 6 program, the dental waiting period change. And that's about it.
Okay, and do we need to approve any of these, or do they just flow through from our previous decisions?
They flow through from your previous decisions.
Okay, great. All right, so that's for information for people. Just one bit of information for the people, the cities and the counties that come in at the supplemental rate, they're not on that forever. Is that true? They eventually migrate to our base rate?
Yep, that's correct, after 3 years.
Okay. And so that's taking in people who might have had very, very high rates. Underwriters say, OEB takes a bath if they take these people. But the assumption is that after 3 years in the goodness of the OEB system, things have gotten better from a rate management issue. Okay.
Yeah, it's also designed to protect OEB,
Right.
from situations where a group could be getting a really big increase and then OEB becomes more enticing.
Right. Okay. Thank you. I think we're then done with what we needed to do in regards to final rates for 24-25. It looks like our next, true, Kirsten? We
We are
covered
all
what we
done with
needed to?
approvals. Yep, thanks
Perfect.
everyone.
Thank you. Okay, so we're now moving on to performance guarantee update. Margaret Isa Smith is going to be taking us through this with help from Mercer Consultants, John and Christy. So are you starting it off, Margaret?
Yeah, let me check in, and I apologize in advance. I am recovering from a cold. John, did you want to? Oh, that's okay. It's
Yeah,
it's been
I'm glad
going
to take
around.
the lead, Margaret,
Sure.
and spare your
Yeah.
voice.
Thank you, and it's not too bad. It's been going around our family, and it's just my turn. So I appreciate it, John, and I am happy to jump in and help and answer questions as well. So if you want to kick us off, I'll be on standby.
Okay, that sounds great, and really appreciate it,
Thanks.
Margaret. Okay, we can move to the next slide. So here's what we're looking to cover today. So good afternoon, board members. I really appreciate you joining this discussion of the performance standards today. So what we're going to do is we're going to cover some background and goals, and then we're going to look at the current performance guarantees, both in terms of the clinical quality and the cost premium growth. And then we'll look at some proposed changes in the guarantees for the 24-25 OEB contract, and these are in the areas of behavioral health network standards and dental clinical standards. And I just, in addition to Margaret, we also have Christy joining us today from Mercer, and she was key in the development of the behavioral health network standards. Okay, next slide. Next slide. Okay, so our goals today are threefold. So first, we're going to review the current performance guarantees. Then we're going to preview some proposed changes to these performance guarantees. And then lastly, we'll be looking for the affirmation from the board to move forward with the proposed changes. And just want to note that these changes have already been vetted both by CIAO and IWG based on which set of changes we're talking about. So the CIAO has vetted the dental clinical standards, and IWG has vetted the behavioral health network standards. So, in terms of how they're structured, so today you have, and we'll start with medical. So today you have 15% of fees at risk, and this is divided up 5% for clinical quality, 5% for cost and premium growth, and 5% for administrative measures. So let's kind of chat really quickly about what's not changing. So let's get that off the table. So the two pieces that aren't changing are the clinical quality measures and the cost and premium growth measures. So those performance guarantees aren't changing. So what we're looking to change for the next contract year is around the administrative measures. And the goal here is really to move the risk away from these administrative measures to areas of greater importance to the board. Because a lot of these administrative measures have really been met over time. So it's really trying to use the performance guarantees to further the goals of both the OEB and the PEB boards. Separately, we also are looking to make some changes to the dental performance guarantees. Currently, there's 10% of fees at risk around the dental performance guarantees. And there are currently some dental clinical standards, but these standards don't have any risk associated with them. And we're also looking to broaden these out in some of the ways that Kirsten mentioned earlier to really improve rural care and things like that. So let me just, and also before continuing, I did also want to acknowledge the good partnership from the health plans as we went through this process of going about changing and refining the PGs. And then Margaret, please feel free to add anything that I may have missed.
Yeah, and John, one clarification I'll just mention, just to make sure that everybody on the board is sort of aware of what we're talking about with the lingo here, is that when we say we have 15% of fees at risk for these performance guarantees in the medical contract, what we're referring to is that's 15% of the administrative fee portion of the premium. And so it's not 15% of the total premium amount at risk. It's 15% of the admin fee portion, which John and Kirsten, keep me honest here, but I believe the administrative fee portion is in the neighborhood of about 5% of the overall premium amount. So it's 15% of that 5%.
Yeah, thanks for the clarification, Margaret. Appreciate that. Next slide. Unless there are any questions. And again, so now we're going to go through briefly the clinical quality measures, and these aren't changing. So we're not proposing any changes, but we wanted to educate the board since we have so many new members about what these measures look like. So currently there are 18 measures. They can be found in the appendix, so then they're listed in the appendix. And these are aligned with calendar year because we use HEDIS to measure the outcomes here. This is a pretty standard in the industry. And then we look at the percentiles. So, and there are different percentiles for the PPO plans and the coordinated care model plans that MOTA has. So those plans are aligned with PPOs, and then Kaiser's plan targets are aligned with the HMO percentiles when it comes to adjudicating these. And again, what we're looking to do on this one is sorry, trying to coordinate my my slides with what's on my notes with what's on the. Yeah, so what we're doing here really is looking at where the HEDIS results come out. Again, HEDIS results are on a calendar year, and so because of the HEDIS measurements that are being used. And there's also, and then there's a whole slide on this later, because it's really important, there are also some performance measures from HEDIS that are aligned with race and ethnicity categories, and these are report only, and we'll get into those in a minute. So unless there anything to add, Margaret?
No, I think that covers it for the overview. Thanks.
Okay. And then on the next slide, it's really how do we adjudicate the clinical quality measures? And so the method is as follows. So the thing is that it's a scorecard approach. So essentially, what happens that for each of the 18 standards, it's adjudicated based on the points. So it's essentially, if the plan reaches the 67th percentile, they get 1 point, 75th 2 points, 90th 3 points. So essentially, this is how they get their points. And then based on their total amount of points across all 18, you can see what happens on the lower piece. So basically, you can see if you get 20 or more points, essentially the plan retains all the fees at risk, and then it kind of goes down from there based on the total number of points. Okay, so, and also the other thing to point out here on the coordinated care model, even though the PPO percentiles are used to adjudicate, there's a higher, as you can see, there's a 22 point target for them. And this is because they're expected to do better than PPOs because of being coordinated.
And just to add to that, the difference, HMO standards or outcomes are nationally consistently above what PPO standards are. It's the reason that OEB has been working towards increasing the coordination of care, no matter what the setting, Kaiser Permanente versus MOTA. We're looking for increasing the organized systems of care and the coordination of care, because the results are better clinical outcomes. And that just is reflected in how HMO standards are actually higher than PPO standards.
Thanks for that, Tom. Yeah, there's definitely value to the integration of care, and that's what you see in those differences, I think.
And John, this is Margaret. One thing I'll
Please.
just chime in and add in terms of, so the whole board sort of understands how we look at this annually. But under the annual reporting cycle, carriers report their results to OEB every year in the July, or the August-September timeframe, so late summer to early fall. And then typically what we do is we have CIAO review carrier results at their October meeting, so that every fall we are systematically reviewing how carriers performed and what the outcome was, and whether any fees at risk settlement is due.
Yeah, thanks for that. I think that's really helpful in understanding the annual cycle, because this is very much an annual cycle, and it does take a long time to get the HEDIS results. I think it's always surprising. You always seem to be, you have a performance year, a measurement year. It's all a bit of a thing. The last slide for this section is about those clinical quality measures regarding race and ethnicity reporting. So while there are no fees at risk or targets associated with this reporting, it is a contractual requirement. And this is the current year is the first year of this reporting requirement. And as such, the first results will be for measurement year 2024. And that we'll get those results, like Margaret was saying, mid-ish 2025. And again, some of the measures that we're looking at on the basis of race and ethnicity are, breast cancer screening, colorectal cancer screening, controlling high blood pressure, well child visits, and, diabetes, H1AC control. And I think that closes it out. Margaret, anything to add on this slide?
No, I think that covers it. Just to note, I believe we have the full list of all 18 measures that are looked at for this performance guarantee in the appendix. So if anyone's curious to see that full list, it's available.
Yeah, thanks for that reminder. We also have the administrative measures listed in the appendix as well. And again, those will be those are listed there so you understand where we're moving the risk away from and to. Moving along to the cost and the cost and premium growth pieces. And again, this is really this is another area, as we mentioned earlier at the outset, that there are no changes proposed here for 2020 for the next contract cycle. And again, we are committed, to work with the medical plans to address any concerns they have about this, about how this performance guarantee works. The basic premise behind this performance guarantee is pretty clear. So the thing is, it's really to align the carriers with the requirements that are placed by, the legislature in terms of achieving the 3.4% a year. And certain adjustments are made in calculating this 3.4% to account for benefit changes and high cost claimants and other factors such as that. The other thing to kind of note here is that, I think that there's also a commitment, to the extent that the 3.4% cap, should that ever be relaxed, that I think, there's obviously an openness to kind of change, this performance standard to match that going forward. Any questions or concerns? If not, we'll move to how is this one adjudicated? So again, pretty straightforward in terms of how this one is adjudicated. If the cost growth is 3.4 or less, there's no penalty. If cost growth is between 3.4 and 4%, essentially half of the amount, the 2.5 of the admin fees. And then if cost growth is higher than 4%, it's the full 5% of administrative fees. And again, this is measured slightly differently for Kaiser. As an integrated system, it's, we look at the premium, and then for MODA and Providence for that matter as well, claims experience is used in measuring this.
And just a little bit more detail on the annual cycle for this one. In order to look at the cost experience, we generally wait for claims run out. We look at the analysis about 9 months after the plan year has ended. So that means for OEB, we'll be looking at the previous contract year, crunching numbers in the next couple months here to have results by midsummer in terms of the contract year that just ended last September 30th. And so again, then early fall will be the time frame for when we'll have an update to the board in terms of what performance was under the previous contract and whether any settlement is due. And if you'll recall, on the most recent contract year settlement, which was for the 21-22 contract, I believe it was in the December, it was attachment 3 in the December board packet where we presented an update to the board in terms of settlement. And in this most recent for the 21-22 plan year under this guarantee, Kaiser ended up with a settlement back to OEB of around $666,000, and the amount was about $1.8 million for MODA. And I think as Kirsten had previously mentioned, those settlement credits were applied prior to settling of final premium rates.
Yeah. Thanks for that, Margaret. That's really helpful. It kind of rounds out some of the recent results. Okay, so moving along, now we're moving into the areas of the proposed changes to the performance guarantees. Let's move on to 13 if we could. And again, the goal is to shift the fees at risk away from the administrative measures, which are for the most part being met, and moving that risk over to the priority areas for the boards around behavioral health access and dental clinical quality. And the goal here ultimately is to improve both the member health and their care experience. And we mentioned this earlier, and I'll just briefly mention it again, that these measures have also gone through a vetting process through the IWG, the Innovation Work Group, and also the dental clinical standards have gone through SIAO in the April meeting. So let's take a little bit of a deeper dive into the behavioral health network standards. And so if you look at this, all the shading, I think it denotes different categories of behavioral health network standards. So the thing is, there are basically 5 areas that these standards fall into. So in-person wait time standards, virtual wait time standards, time and distance standards, provider diversity, and provider demographics in the directory. So essentially, and so then we have standards that address each of these areas, as you can see. So appointment wait time standards for in-person, there's standards around panels being open, because I think there's a lot of concern about, these ghost networks where yes, there's a panel, but the thing is that nobody's open. So again, these are some of the standards that are trying to address those concerns around access. Many of these standards, as you'll see, are looking at different aspects of access. So access to, in terms of time, time to appointment access is what you're seeing in this first grouping. And the second grouping, it's really how quickly can you get an appointment. And then the time and distance standard is really looking at a different aspect of access, which is, how long does it take you to get to see, to provide, distance to travel to that office. And then you also have provider diversity, and this again, self-reported, and again, trying to move things in this direction. So the other thing too, so there's 5% at risk currently with the administrative standards, and this would be moved to these behavioral health network standards, next year. The other thought here would be that 2025 would be a baseline year. So the thing is, the risk is really just around, do you report or not? And then the 2026 would be, that baseline data would be used for setting, fees at risk in 2026. Christy, is there anything else that you want to highlight? I was trying to avoid going through each one in detail, but are there any standards that you'd like to particularly point out?
Not one in particular. I actually want to point out that it's really the combination of these standards all together which are going to make the meaningful difference. Because if you pull one apart and you just look at that, like wait time standards, in and of themselves are important, but until you add time and distance to that, that's where you get that more comprehensive approach to what are some meaningful network standards. And I think that was really part of our goal, is to make sure that we were coming up with meaningful standards based on what we see. And as you can see here, we have some really strong sources to pull from for these standards. My last thing I just wanted to share is that I think the carriers have been really good partners in this. We've had lots of dialogue back and forth, I think to really land on a good place to start from for some meaningful network standards.
Yeah, and this is Tom. The only additional thing that the IWG met at the end of April, where we agreed to bring these forward to our boards. The specifications of these need to be cleared by our OEBB staff with Mercer and the carriers, because the devil's always in the detail. These, where there are some that you'll see, like Medicare, under that light blue, the time distance standards, Medicare, the specifications are all very clearly worked out for that. Things like urgent appointments available in 48 hours in person. The specifications may be clear, but if the plans are going to be held to something, they need to know specifically how it's going to be measured. You know, who's included, who's not, what the process is. So the good news is that we have the summertime for staff, for Mercer, for OEBB, and the carriers to come to agreement around the specifications of these standards.
Thanks for that, Tom. Yeah, I think that that's an excellent point, that it is in the details. And I think part of the challenge with the behavioral health network standards is, unlike the medical, there's not easy benchmarks out there. I mean, I think that's part of the challenge here, that we're kind of blazing new territory here. And that's why we're appreciative of the plans to partner with us as we move this forward. Yeah. Margaret, any thoughts on these?
No, I don't think I have anything further to add. I think we're again looking at, I think as was mentioned, we would have the first year for 2025 be report only year, and we would use that data captured in 2025 to help us set targets and goals for the 2026 plan year to go in the subsequent renewal contract. So a glide path, I think, multi-year effort to really look at these measures, but this is our approach proposed for the initial year.
Yeah, thanks. I think that's good clarification.
Any question or comment from the board? This is the part that's obviously new. And I think that at the innovation work group, there was clear interest of moving away from looking at administrative outcomes, because they didn't really approach what was happening. They were set and stable, and we knew that behavioral health was such a major part of the care that we're trying to provide our members. Okay, well, let's go ahead and move on.
Oh, Enrique has a question, I think.
Oh, good. I didn't see it.
Yes.
Enrique.
Thank you, Tom. Thank you, everybody. I do have one question, and maybe this is not the time, but I think it is, because we're talking about behavioral health network standards, and we just approved the rates, and you have been discussing the last couple months on the providers and diversity and demographics. I was wondering if at some point today, or when it'll be permissible to request or ask a report of the sexual orientation, since it says right there in the category LGBTQI plus. So that made me think of when will be the best time for us to hear a report from providers on where they stand with that. I know Kaiser has some programs for the community, so I was just wondering if this is the time, or is it later on?
So just to clarify, go ahead, Tom.
I didn't say anything.
Okay. Yeah, so I think that's something that we could ask of the plans, Enrique, and report back to you. And we might have some things that are already available in the renewal.
Yeah, this is Ollie. Just to quickly jump in, we generally have a really extensive report from the carriers on access and diversity of the providers in the fall. So we can work with you and OEBB leadership, Enrique, to see what we've done in the past and maybe how we can move that forward and cover everything that you're envisioning as well.
Yeah, that'd be great. Maybe a good refresher for the board. I know the fall was quite some time, and I think as we wrap up this academic year and our board meeting, for me, will be helpful when I meet with OEBB members across the state, have sort of like a 4 or 5 page summary of like what we have discussed, and a very successful year, I think, and that's how I look at it, and be able to provide, because these questions come up, where is OEBB with the LGBTQ plus IA community and gender affirmation and all those things that we hear about. So I think it'll be helpful for, I think not only for me, but I think the rest of the board members. Thank you.
Yeah. Yep.
Thanks, Enrique. A great idea. So moving on into the dental clinical standards. So moving on to page 17. So this is really the current dental standards there are 8 of them. 5 are operational and 3 are clinical. So the clinical measures are not all new, but the thing is currently the clinical measures are report only. So there's no risk associated with them. And they're involved also in the adjudication on a report only basis. And as we talked about earlier, 10% of the administrative fees are at risk, and a scorecard methodology is being used as it's described on the right. So based on how many of the standards are met, essentially, your payout is dependent on that. So this really kind of is the current what it looks like today. Any questions, Margaret? Did you want to add anything here?
No, I think this is a great summary on this slide.
Okay, so moving on to the next slide. So there's a lot here. So the thing is, first, let's focus on what's not changing. So going forward, we're proposing to continue to have a total of 8 standards, and the goal here is not to dilute the value of each standard. So we're still going to keep a total of 8. And in addition, we'll also keep the same approach towards adjudication that is today that you just saw in the prior slide. So using that scorecard approach. So what is changing? So the first thing that's changing is fewer administrative standards. And you can see that, today there are 5, and you can see how everybody's losing at least one of those, and it's being displaced by either a legacy clinical standard or a new clinical standard or a new access standard, because that's the other thing that we did change. So, and then again, you can see that in the green. And our goal is, and this is where we're still working out the details with the plans here, because we're trying to figure out which of the administrative standards will be retained. And the goal is to retain those that are most meaningful from the collection on the left of the prior slide. So the second piece is having risk associated with some of the legacy, the pre-existing clinical measures. And that's what you see in blue here. And that differs a little bit across the plans. And then the third thing that is changing is really what you see in purple, which is really the new clinical or access measures that have been discussed with the plans. So I think it's really important to notice here that there is some slight variation across plans. Not everything is the same like today. And this relates to just the state of data in dental versus medical, because you don't have the same national benchmarks in dental as you do in medical. So there's a slightly different approach. We worked on being flexible with the plans and having, allowing for some differences where it made sense. And I think the other thing to kind of point out is really, something that we talked about earlier, which is, looking at that rural and, so you can see if you look at the Delta/MODA new performance guarantees, they're putting something around measuring it for the rural population, setting up specific targets for the rural population, both for adult and children. And then for Kaiser, they're building on where their strengths are, which is really closing those care gap summary, because as an integrated system, it's really just, second nature for them to be able to do some of these things. You come in for your dental, they remind you about your mammogram, what have you. So I think that's, so it's really looking at the strengths of each of your plans today and building on those, with regards to these standards. Let me pause there. Margaret, anything you want to add?
Yeah, just to reinforce what John mentioned, I want to acknowledge up front Generally speaking, we try to have consistent measures for our carriers across our contracts so that we have sort of apples to apples comparison. But as John noted, that's a lot easier accomplished in the medical carriers where there's more sort of nationally developed and benchmarked measures available. A little bit more challenging to do that in dental. However, when we looked across carriers for these dental measures, we did have a certain aim, which was to ensure that every carrier had some administrative measures, some measures that focused on prevention, some measurement that focused on kind of a priority population, be that rural adults or individuals with chronic disease, diabetes, and then also a measure that looked at kind of member satisfaction around access. So we tried to hit all of those dimensions across each of the three carriers, even though the specific measures vary somewhat between the carriers. So just wanted to kind of note that we try to adhere to those themes in the process.
Thanks. That really kind of rounds it out nicely. Any questions from the board?
In terms of process now, I would like, you've seen the outline of the measures. As usual, there is a certain amount of work in progress, specifically for the behavioral health network standards and the dental standards. There still is work that's occurring this summer around what the specifications, the details, the baseline, and what the targets are going to be. But I think what we have is a pretty coherent set of measurement of standards that are going to be part of the performance guarantee process. So if the board is ready, I think it's not unreasonable that we have a motion to accept the medical, the series of performance guarantee standards that we have just finished outlining. Again, if the board wanted to vote on them individually, we could do that. But there wasn't, as we've gone through this conversation now for about 40 minutes, there really hasn't been controversy around, no one has raised controversy around any of them. So I would like, though, the board to actively approve these standards.
I move to adopt the standards as presented on to the OEB board.
That's Enrique. Is there a second?
This is Cheryl. I'll
Second. Yeah.
Thank you, Cheryl. Okay, so we have a second from Cheryl. Okay, any additional questions, comments, or statements before we have a vote? Okay, all in favor? Actually, I'm going to go down the list for this one just to make sure. Enrique.
Yes.
Cheryl.
Yes.
Michelle.
Yes.
Sally.
Yes.
Bill.
Yes.
Bonnie.
Yes.
Susan Miller.
Yes.
Sue Ricky Smith.
Yes.
Robert Young.
Yes.
Absent is, I think, still Bob. Bob, are you there? No. Okay. So again, unanimously approved. Thank you very much.
Thank you.
I think that I would hope that OEB staff with Mercer would be able to come back to the board in September or October and just give a brief update on the specifications that we were able to come up with for both the dental standards and the behavioral health network standards. I
we can
have it
certainly do
exact.
that.
Super. So I have it at 2:45, exactly when we're supposed to have our break. So thank Margaret and John and Christy. Thank you very much for getting us through that, and really appreciate it. So 10 minutes. We'll actually, it's now 2:46. We'll reconvene at 2:56.
Thank you.
Thank you.
Okay, it is 2:56 and we are back at it. The next agenda item is the EAP RFP update. And John, you and Brian are going to take us through this?
Yeah, I'll take us through it.
Okay,
So
great.
yeah, I don't think we'll need the full 15 minutes. Feel free to ask any questions. So just a couple points that I want to bring up for the board. You know, we're about 3 weeks into the implementation, and things are tracking on schedule for implementing on October 1. Canopy will be introduced to the OEB entities as part of their, the entity open enrollment process that occurs in the May-June timeframe. And that's when the entities decide on which plans they are going to offer, and also they decide whether they're going to include the EAP as part of their offerings to their members. In terms of negotiations, we've reached a tentative agreement on the rates, and are in the process of negotiating, other portions of the contract, including the performance guarantees. So while unlikely, if an agreement cannot be reached with Canopy, the board would need to, consider the next highest proposer, or if needed, we also have the backup of the Uprise renewal. So that's really where we stand at this point with the Canopy implementation and negotiations.
So, John, is there at this point, if all goes as you hope, the board doesn't really have to do anything else at this point? It would only be if there was some breakdown between OEB contracting with Canopy.
Yeah, that is our understanding. Yeah.
Super. Okay. Any questions or comments from board members? Well, you really did save us a lot of time on that one. That was well played, as they say. Okay. Bill, next agenda item is CIAO update.
Yep. At our meeting this morning, and the two topics were discussed. The first one is for summer research group, and the second topic was an outlook on the upcoming trends in medical research and medical technology. Item one, for the summer research group, CIAO is going to recommend a research group put together for what we call traditional health workers, what the state calls traditional health workers, to do some background and some data gathering on what they are and how they work. The purpose of the traditional health worker concept and bringing into expanded coverage into the OEB network is to bring in more coverage and fill the gaps in rural areas. And it's also a good opportunity to bring in additional provider workforce to help close the gaps and meet diverse needs of members. Traditional healthcare workers are controlled by the state of Oregon. There are rules and regulations around them. Example is one of them is doula, which we approved last year. But there's a lot of other traditional healthcare workers, especially in professional health navigators, peer wellness support, community healthcare workers in general, just to help out, provide health education and information, assist community residents in receiving care, doing some guidance and understanding in health behavior type work. Training and certification requirements are controlled by the state. And so we want to take a work group, put together a work group with OEBB this summer to look at what traditional healthcare workers can offer in bringing into our coverages and how they might do better for our memberships. That'll be, again, put together just like we did last summer. We had two work groups, one for doulas and one for GLP-1 work. It'll be twice monthly meetings, and they will meet throughout the summer and provide back a recommendation to the board in the September-October timeframe. The second thing we discussed was basically general goals for the CL work plan network and what we talked about in the scoping of what CL is doing, strategy, advancement, assessment, opportunity, and accountability. And we spent a very interesting hour and a half or so talking about innovation in the healthcare industry, looking at lots of things, including AI, genomics, omnics, data, robotics kind of stuff. The first main topic we talked about was genetic screening, and looking at how the innovations in upcoming healthcare technologies look at genetic screening and how they pull that together and evaluating health risk. It's a little ways out, but it is a lot of work being done there, especially in cancer screening rates and early cancer detection. Looking at genetic data as well for risk factors, which we just did with our approving of Gabi here in this renewal rate for healthcare. There's a lot of work being done in multi-cancer early detection in using these types of techniques as well. And a little bit of talk about vaccines for cancer. That's way out there in the future, but it was just an interesting point to know that a lot of research is being done in that area. For personal genetic data, there's nutrigenomics and gastrointestinal microbiome work being done where you look at people's genetic data and try to adjust their well-being through various types of personal health care. Let's see, personalized treatment in genetics as well. We talked about. Next topic was gene and cell therapy research that's being done, especially targeted around blood, spinal muscular atrophy, hemophilia, sickle cell, and various types of cancer, and how the difference between gene therapy and cell therapy is coming through the research. And again, these are way out in the future, but something to discuss because some of them are in actually approved and coming soon through government approval. And other conditions we talked about, HIV, new types of HIV treatments that are being in the pipeline. There is just a huge quantity of GLP-1 weight loss drug, not just GLP-1, but weight loss drug pipeline has got, upwards of, 30, 40, I can't even count them all, in the way of new drugs coming out or going into testing. 2, 4, 6, 10 of them in phase 3 clinical testing right now. One of the things was brought up was one of the things that is really on the edge of coming in here, similar to like how GLP-1s came online, is fatty liver disease, and talking about how not all liver disease or cirrhosis is caused by alcohol consumption, but there's a lot of new discussions on what causes fatty liver disease, and there's a lot of treatments and studies going on right now in covering that might be here sooner than we well, no, not sooner than we soon, very coming on soon, I should say, and it's a large amount of money coming into that. The last topic we discussed was digital healthcare, which includes wearables, devices, as well as portable devices like the mobile EKG stuff you see on TV. There's a lot of wearable devices now that control diabetes, depression, personal health rates, and all of these new functions, and that younger generations are buying into this new wearable technology, which includes the collection of data, things of that nature, and discussion of how you can improve your own personal health, and with motivational data showing how to accomplish those goals. Very popular now. OHSU has come out with an app for your iPhone for skin cancer screening called Mole Mapper, where you take pictures and locations of your moles and it keeps track of them for you. for skin cancer diagnosis. There's also some OHSU has some home programs for monitoring of preemies, or basically babies born at risk, so that they can go home earlier, get them out of the hospital environment and get them into the home environment. Not just good for the baby's well-being, but also gets them away from generic hospital risks, such as viral infections and things that go on in hospitals that you definitely don't want preemies exposed to, if they're as least minimal as possible. There's a lot of app-based app therapy for clinicians and clinical diagnosis to be done. And then there's big data. And this is where we're collecting all this information, putting together. There's a project called Healthy Oregon Projects, where over 30,000 Oregonians are participating in this data collection, called HOP, Healthy Oregon Project, looking at causes of cancer and chronic diseases and basically collecting personal health data. So we had a really good discussion about where a lot of things. It's not everything that's going on in medicine, obviously, and it's not everything that we're going to look at and see how, but really just an overall picture of a lot of good work that's being done in medical research and what's coming our way in the future, both near and far. And I'll stop there. Uh-oh. Did nobody hear what I said?
Any questions or comments? Yeah, any questions or comments for Bill? Thank you, Bill. It was a very interesting morning to have our minds expanded in terms of what could be happening, and then trying to figure out, of all those things, you know, what are most pressing for CIAO to be looking at and bringing to the board. Okay, we can now move on. Next is the director's update. Ali?
Yeah, thanks, Tom. Just a couple quick updates. Wanted to give an update on board member replacement. So staff been working diligently with the various constituent groups of OEB and also the OEB advisory group to help identify the most qualified, motivated individuals who will bring relevant experience to OEB. And for some background on the process, OEB constituent groups are responsible for filling their open positions on the board, but staff does take lead on the health policy experts and the local government management positions. And we all work with the governor's office to identify the top candidates to put forward for Senate confirmation. And I know that Sue and Robert and Bob's replacement process is well underway and progressing. For Tom's health policy expert position replacement, we have a list of people that we're working through, and again, we're dedicated to finding a great fit. The next Senate confirmation takes place later this summer, so we're hoping to have new board members when OEB reconvenes after the summer break. And just to remember, a reminder that the OEB board does not meet during the summer, so July and August there is no board meeting. I did mention the new OEB entrance update earlier. We do have Medford School District coming to OEB October 1st. Again, 1,100 employees is really significant as OEB expands its statewide footprint. And again, I think this is a testament to OEB's value proposition. We're close to adding 2 other mid-size entities and are adding a small charter school in July. We're talking to new eligible entities all the time. And we probably should bring an update to the board on kind of where things stand, what we're hearing from folks and around the state, and just general interest in anything that's holding people back. Also wanted to give a quick update on the board's legislative concept that addresses the shortcomings of that 3.4% statutory cap that we've wrestled with the last few months. And if you recall, this legislative concept could include like reassessing how the cap is calculated over time to allow for greater flexibility or allow greater flexibility around maintaining compliance with the statewide cost growth program. There's still a long way to go, but just getting through these first rounds of review is encouraging. So lastly, just wanted to say thank you to Tom. I think, we do have Sue and Bob for one more month, but this is it for Tom. It's hard to believe. And when I reflect on the amount of time that Tom has given to OEB and its members, it's really saying thank you just doesn't seem adequate. So when we see new entities joining OEB, and others interested in hearing more about OEB, and there's really a direct line from his leadership and CIAO and the board from that interest. And while replacing Tom on the board is kind of an impossible task, we will do our best, and we do see some pretty good candidates, and Tom's actually helping with that. So speaking for staff, Tom, I do just want to say thank you and just the best to you and your family and your true retirement, and may you enjoy all the happiness in the world. So thank you.
Very kind of you. Thank you, Ali. Yeah. It's been a very meaningful 8 years. This has been hard work, but it's been good work, and it's been a way for me to keep my brain going, because there have been a lot of challenges that we've all had to deal with. Wonderful people to work with in our consultants, OEB staff, other board members, consultants. It's been great. I've really enjoyed my time. Thank you.
Welcome.
Is there any other business that needs to be brought forward? And Rose, do we have any public comments?
No, you have no public comment.
Okay. If there's no other, if there's nothing else, I will adjourn the May board meeting. Good luck, all.
Thank you.
Bye-bye.
Thanks, Tom.
Thank you, Tom.
Thanks, Tom.
Yeah.
Thank you,
Thank you, Tom.
Bye-bye.
What the hell is going on with this thing?
Bye, Tom. Thank you.
Bye.